Well, good morning, everybody. Welcome to the Osher Center for Integrative Medicine Grand Rounds. This is our research month that alternates with our clinical month. So pleased to have you all here. Before we get started and before I introduce our speaker, I wanted to just alert you to our website and just orient you a little bit and just encourage you to take advantage of the resources and the information that's on there. It's oshercenter.org, and it's a lovely website, and our website builder is here today, Atra Nusrat. And you can learn all about the different programs within our Osher Center. You can scroll down and you can see highlights that's in the news, activities that happen in integrative medicine in general, as well as in our center. There's information about the current and future grand rounds, as well as historic ones, so you can go listen to some of the lectures that you missed. Most of them are archived on our internet. You can also scroll down, learn about grant opportunities and people who've recently received awards. And then finally, you can go play with our new clinical map and find clinicians across the Harvard Medical School system that offer integrated therapies, as well as our research map. So please take advantage of these resources. So I have the distinct pleasure this morning of introducing our speaker, Dr. Leon Morales-Quezada, who's actually our first NIH Integrative Medicine Fellow to present in our research grand rounds. Leon has accomplished a tremendous amount in his early career. So after graduating from medical school in 2000 at the Universidad Autónoma de Aguascalientes in Mexico, I've been practicing that. He completed a variety of residencies, including a fellowship in neurorehabilitation and brain development in Philadelphia. Then to advance his interests in research as well as clinical skills, he completed a master's in clinical rehab and neuropsychology at Truro College in New York. And then he went on to do a PhD in neurosciences at De Montfort University in the UK. If that wasn't enough, he came back here and did a master's in public health with a focus in clinical effectiveness here at the Harvard Chan School of Public Health while he was a T32 fellow in our program. And he currently serves as the Associate Research Director at Spaulding Rehabilitation Hospital's Neuromodulation Center. Finally, he's a core member of the Harvard program in placebo and therapeutic encounters led by Professor Ted Kapchak, who spoke here as well recently. And today, Leon's talk remarkably brings a lot of this together, and his presentation is going to be on the use of placebo and the study of placebo, specifically within a clinical context. So please join me in welcoming Dr. Leon Morales-Quezada.
Good morning, all. Thank you for being here. Well, thank you, everyone, to be here. Thank you, Peter. Thank you, Helen, for the invitation. And I'm very happy and proud to be in front of this audience here in Brigham Women's. I'm going, as Peter mentioned, I'm going to talk about the placebos. There has been a lot of research in the last 20 years about placebos, but now I'm focusing more a little bit in how we can start thinking about to use placebos in the clinical arena. There are not interests involved in this talk. I might talk a little bit about the use of transcranial direct current stimulation. That is one of the techniques that we use in our center as an FDA off-label, which is not approved by the FDA, and it has some off-label applications by now. So let's start with some historical background and principles about the placebo, how it was conceived over the time, the contemporary view of placebos and the research that has been done mostly in a controlled environment, to move into the neurobiology of the placebo effect by itself, the phenomena that it has some biological phenomena moving on into the expression of this effect that we can see either in clinical research but also in clinical practice. And then we will discuss a little bit between the difference in hidden versus open placebo, which is now making the big difference of how to use placebos here in the clinic with our patients. So for many time, placebos, they have been part of our practice. For very ancient times, it was described mostly because there were efficacy of bizarre treatments, and there are a huge compendium of medical compositor. I'm talking about different weird and different remedies that were used over the time. In our field, in non-invasive neuromodulation, it was well known that in ancient times, Roman and Grecian times, physicians, they used electrical charges from these fish, the torpedo fish, to treat headaches, seizures, nostalgia, or depression, which basically is the same kind of conditions that we are treating now with TDCS or transcranial magnetic stimulation. So many centuries ago, those physicians, they have this idea that the electrical currents, they have an effect in the brain, and they didn't have that technology. So they just basically took this electrical fish and put it on the head of these patients. To go into the details of the nomenclature about placebos, placebos basically is coming from the Latin word of I shall please. So it's originally conceived to please rather to treat patients. Placebo response is anything that happened in the control group, regardless of or independently of the natural history of the disease, regression to the mean, and the placebo effect by itself is something that is not spontaneous, and it can be directly attributed to the interaction between the practitioner, the researcher, or the environment around the patient, or in this case, the subject in research. The Oxford Dictionary in 1855, they came with this definition that a medicine given more to please than benefit the patient. So they put already the label of medicine, but without any real treatment effect, just to make the patient happy. And later on, there were some factors involving in the expression of placebo when you have some sham treatment, fake treatment, and therefore you have some clinical improvement. You can give the responsibility to that, to the spontaneous improvement due to the natural history of the disease, the statistical regression to the mean, psychosocial factors playing in the patient, in the experimenter or physician, biases, any kind of biases that you can include here, and also the presence and effect of co-interventions, if the patient was taking any other medication, any other form of treatment that can influence that clinical improvement. In the Royal College of Physicians in Edinburgh, there is one of the first official expressions that some clinicians were using placebo, basically to placate the anxiety of patients. I own that I did not trust much to it, but I gave it because it is necessary to give medicine, and as I would call a placebo. This rationale, I know a lot of my colleagues, pediatricians, they tend to have this way of thinking when dealing with the parents. So it's not that you really believe of that, but basically you need to placate anxiety of the familiar or the patient by itself. And then some thinkers, Thomas Jefferson, wasn't very nice with the field of medicine and basically said that physicians use more bread pills, drops of colored water, powders of hickory ashes, and all other medicines put together. And believe it or not, he actually mentioned, and yet patients, they seem to benefit from this. But there was a point in history where the transition of placebo came more into the skepticism about some healing techniques. So Benjamin Franklin was appointed by Louis XVI to test mesmerism, a form of treatment using the energy of the healer. So he actually was the first one to create the first blind assessment because he put the patients, they blind them, they cover their eyes, and then he used different people just to provide this energy. And he basically showed that that energy didn't work when you change different practitioners, or in some cases it worked with all of them. John Hygarth used sham rods to debunk Parkinsonism. They use specific metal rods to treat maladies. So he created a sham rod. So was the first one to create a sham device in a kind of primal clinical trial. And later on, Armand Trousseau, when testing the homeopathy, used the first placebo pill, which in this case was a bread pill. And he noticed that some patients responded to the placebo pill, and he attributed that to the imagination of the patient. So it was the first time that somebody was putting into the ground that there was something going in within the patient interaction and the practitioner providing this form of therapy. So, and then gradually we start moving into the field of clinical research. And a medic in the battlefield run out of morphine. So what you do when you have somebody with terrible injuries there, well, he just did what he thought was the best thing to do at that moment. Replaced the morphine with saline and told those injured that it was actually morphine. To his surprise, almost 40% of these patients in the battlefield responded that there was a resolution of his pain. So Henry Beecher came to Harvard, became an anesthesiologist and a famous bioethicist. And because his experience in the Second World War, he did this famous study that basically said that no matter what you do, he came with this number over here, about 30% of your patients, they will respond to whatever you do. But beyond that, he also observed that even in the placebo group, there were some adverse effects. So what we start talking now, nocebo effects. That was the first structural research showing that placebos really have some effect and that we need to start considering that they are not only just noise into the statistical analysis. So in clinical trials, we start using placebo as the enemy to defeat. It's the gold standard for us, the efficacy of the treatment over placebo. In clinical research, practitioners are still using it. And it became now an excellent model to see the interaction between body and the mind. Opposite to that, in the dark side of placebo, we have the nocebo effect, which is basically the opposite. I'm not going to talk much about that because it's becoming another field of research for us. And the National Survey for Placebo Usage is saying that at least half of the medical practitioners in this country are using one of these forms of placebo. However, if you have a diabetic patient and you don't feel sure or secure prescribing sugar pills, well, now you can go to Amazon and get SIBO, honest placebo pills designed to help you to create safe experience on your path to well-being. And to please the meth organic people, the yuppies and hipsters, the active ingredient is no active ingredient. And there is no daily values established for a non-active ingredient. So we have been in contact with the manufacturers of this placebo. We actually were thinking to start using this placebo in some of our studies. They came back with, obviously, there is not FDA study or approval for this, but they provide a quality of the pill by itself. So it's supposed to be a complete inert placebo substance. So there is only the cellulose and the coloring dyes that they use to paint the capsules, because they figure out that blue and white, it have a strong effect in the patients taking it, because they really look like medication. So, well, we know our imagination can modify the effect of a clinical research. So we introduced the blind assessment to try to get rid of that. We start identifying the natural course of the disease. So we can predict, well, this patient has X condition, in 10 days he's going to be better. So we can account that into our analysis. We know that there are biases in both in the clinical and the scientific teams. And when we have difficult interventions like surgeries, medical devices, then we start using what we call an active placebo, just to try to counterbalance the effect of the inert substance or device. The psychological perspective, it puts a lot of factors into why the placebo is expressed. So first of all, the doctor-patient relationship, expectations, patient's personality and psychosocial state, severity of the symptoms. This is something that we see pretty much in our Parkinson's subjects in the lab with non-invasive brain stimulation, the last resource bias in relationship with the severity of the symptoms. They basically kind of want to please the research team. And they say that they are feeling better even though that they are in the sham group. The type of verbal instructions, well, especially here in Boston, in our efforts to recruit more subjects, our fellows, they start offering some sort of hopes during the phone interviews. Well, it might work. Some of our patients, they respond well. So you are preparing everything. And developmental milieu is very different if you just go into a dark cave or to this fancy set of hospital environments, right? So the therapeutic rituals is something that came very, very strong for the placebo group, because the medical anthropologists, in this case, Eric Jacobson, really here in Boston, they start saying, well, everything that is surrounding you, it has a strong effect in the psyche of the patient. The interaction that you have with them, the way that you talk with them, the way that you dress, the white coat, the tie, how you present your confidence about the treatment, all of that has a strong impact in the psyche of the patient. And in the past, there was the witch doctor praying, singing, using sensory stimulation with odors, incense, sometimes painful with manipulations. But all of that was a ritual that predisposed the subject or patient to respond. How different is with that? I'm not using this odd custom, but I have a sophisticated equipment in the lab. I'm showing the brain to the patient. There is sensory stimulation because this coil is basically a magnetic coil just like an MRI. So every time that they deliver a pulse, there is a tick, 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 tick. And also you can feel the pulse on your head. So all of that, and then you have the omnipresent optical reader just in front of you, waiting and looking to you all the time. So that's the ritual of the practice of non-invasive brain stimulation in this case. And we completed a study in motor recovery after a stroke using this device for FDA approval, a multi-center trial, 13 centers around the country, the best of them, Mayo, Johns Hopkins, NYU, everybody was there. That was me. Everybody improved. The treatment group and the sham group improved. Everybody improved. There wasn't any difference at all. Why? We believe that the ritual of the stimulation itself, it really had an impact on this. So there were many factors described there, but I want you to focus here, experimental subordination in the case of clinical research, and we can say also patient subordination when we are exposing all of this into the clinical arena. So it sounds a little bit derogatory because the subordination, but it really has an effect. So whatever you say, whatever you present to the subject in a clinical trial or your patient in practice. But it wasn't until Fields and Levine in the 50s, no, this in the 80s, they say, well, we know that there is a natural history of the disease. We know that it follows this. There is a pointer, a peak, and then everything is just improvement. So what about if we introduce the placebo before this peak and observe the difference? And if there is any difference, then we can say that this is because the result of the placebo effect. So what they did, basically they tried to suppress pain, induced by placebo, and then tried to block that effect with naloxone. So there is the natural course of the disease, there is the placebo, and there is naloxone. So they actually showed that there was some common pathways in the placebo analgesia mediated by opioidergic pathways. Later on, the group from University of Turin, Amancio and Benedetti, they did a very nice experiment showing two patients in a hidden placebo design with conditioning of ketorolac. This is baseline. Oh, Can you see it here? This is baseline. And then the injection of ketorolac, and then an open injection of saline, telling the patients this is ketorolac, and you see how the saline mimic the response of ketorolac. Here, they did the same, but instead of saline, they add naloxone, an antagonist for the ketorolac, and there was a partial blocking of the effect of the ketorolac. In a third group, they did the same with ketorolac, and there this was conditioning on expectations. They told the subjects, the saline is ketorolac, so your pain is going to be suppressed. But then later they did the same without expectations, ketorolac, saline, where they told them there was just an antibiotic, and there was some form of mimicking effect of ketorolac without the magnitude of the first one. And then in the second group, they actually used naloxone, and they told them it is an antibiotic, and it failed to suppress the effect like in the first case. So it really, it had different effects the way that you presented the placebo. You say it's normal or not, or if it's just an antibiotic, it actually blocked the effect of the antagonist in this case. Yep.
This top figure with the red line, are
Yeah.
those two supposed to be statistically different?
No, this is just to show the magnitude of the effect here, how the naloxone.
There's enough spread in between the two that they're about the same.
Yeah, there is the spread, but it was a partial effect here. So it's what we are observing. And then we know that the opioids are not only the only neurotransmitter in placebo analgesia, but this is the first studies that they really show that that it wasn't just imagination, that opioergic neurotransmission was involved. It was replicated later, and then other neurotransmitters came, other antagonists came. And 4 weeks ago, Lena Bayes from Denmark came. She's doing more research into the nocebo effect. They are failing to show a neurotransmitter. It seems that everybody wants to look for the ideal neurotransmitter to use as a marker of placebo responders. At least in the nocebo part of this, is kind of not very well understood. But the psychobiology now is telling us that, well, it's not just your imagination, that something is happening just by chance. There are some effects happening, those changes happening at least at a central level. And expectations is not just like you want to believe. It really has some effects on neural centers, and memory and motivation is influencing this phenomena. And then, based on the basic circuitry that we know for reward, for high cognitive functioning, and also the interaction with some areas that into the controlling the matrix of pain, then the first studies came showing now in imaging, this is neuroimaging, the placebo responders that show activation of opioid and also dopaminergic signaling in response to placebo analgesia. These are two different studies, the Subieta and De La Fuente. They show that it's not only the pain matrix, like the periaqueductal area in the brain, but other highly sophisticated prefrontal structures, dorsolateral prefrontal cortex, the dorsal anterior cingulate cortex, involved with expectations, reward, cognitive and emotional integration, and obviously the pain control. And in both cases, in functional MRI and also in PET studies, this effect was there, it was present. So placebo non-responders showed reduction in the regional opioid and dopaminergic activity. So people who do not respond to the placebo analgesia, they didn't have this kind of neurobiological signatures in the imaging studies. And then in Parkinson, the Parkinson model, I told you that in Parkinson expectations, they play an important role. So here they were basically looking to the neural correlates of reward associated with anticipation of the placebo response. So this is very important. 4 groups. Group A, they told them, you know what, we have this new anti-Parkinsonian medication, but you will have 25% chance to receive it. Group B, they said, we have this new medication. You have 50% chance to receive the medication. Group C, you have 75% chance. Group D, 100% chance. They told them, you will get the medication. And this is the clinical improvements in the UPDRS. You see this nice correlation, and these guys just killed the expectation. They were sure, oh, we will get a new drug. There wasn't any clinical effect. So uncertainty in this case, at least the chance to gamble that there is some hope for you that you might get it, it really played a role here. And then when they did the PET scan using the radio tracer, I don't remember the radio tracer, what was that? Raclopride. It shows an increased binding of dopamine in the placebo group. So this is the baseline. This is with levodopa. This is the placebo group. So you see that decrease in the signal of the radio tracer just because there is more dopamine being binded there. And this happened obviously at the putamen level over here, but also in other areas of the brain that actually help to control and to get the clinical response to these patients. So it was fascinating and the first time to see that not only the expectation was able to be measured, both in clinical effectiveness, but also in neuroimaging. So then we say, well, dopamine was involved here, and dopamine is heavily influencing the learning networks. We know that it's one of the best precursors for long-term potentiation and long-term depression, the heavy mechanisms of neuroplasticity. The biochemistry of that is well understood at this point. We know that there is glutamatergic activity, AMPA and MDA receptors involved. So the reward, the expectation, and more important, the conditioning of the stimuli might facilitate the learning of this and then have a response. So we can apply this in the form of Pavlovian pharmacology. It's not the traditional ringing the bell and get the dogs to draw, but it's more to present a stimuli. In this case, unconditioned stimuli that naturally leads to a response, and then pairing that with a substance that it doesn't have any effect over time in order to get some learning effect. So for you to get it in a little bit better shape, you have a drug. You can say any drug with an effect that we know. You give the drug, you expect to see a physiological change. You have a neutral stimuli without known effect. You give it to the subject, and you are not expecting to see any physiological changes. But what happened in an acquisition phase, or let's call learning phase, when you put together the unconditioned stimulus, the drug, let's say levodopa, plus the placebo, and you give this over a period of time, you still get your physiological change, but in some point you just remove the active agent, you remove the drug, you leave just your inert substance or your sham device or your placebo, and this by itself, thanks to the previous conditioning during the acquisition phase, you will be able to get some response. So the unconditioned stimuli in pharmacological testing, it basically will exert the response at the central nervous system. The unconditioned response is specified by the actions that the organism generates in response to this. And the conditioned response, the response to the inert substance, is just a synergetic phenomena, and agonistically and that is used by sensitization mechanisms. But why expectations are important here? Again, Colloc and Benedetti, they did this experiment. So in post-surgical patients, they told them, you will receive the methamisole, an analgesic. They talk about it in the beginning, and then they will measure the pain intensity over a period of time. So you can see that they came, they show the drug, they inject the drug, and you see a response over there. In the other group, in the control group, they just mentioned that they might receive a drug, but they didn't come and show the drug. It was just a device that it was supposed to inject the drug by itself. So it was a hidden or unexpected injection of methamisole. So what happened? And yet the medication was applied over here. But without expectation, it really didn't have any effect. So we know that conditioning is important. We know that expectation is important. One is conscious, the other one is not conscious. There is now a lot of debate in the psychology field, what is more important. I believe it's really an interaction of the two of them. If you have an input and an output, the mediator, either conscious or not non-conscious, it may lead you to the effect. So either you do the classical conditioning procedures, or you also interact with the subject, which really is what we do. It's a combination of these two. But in one of the best examples of conditioning, I really love this study, and the faculty at Osher, they know that I'm dying to replicate this. But this is Parkinsonian patients that were exposed to deep brain stimulation, but before they activate the stimulator, they use the device to record the neural activity of the subthalamic nuclei. So here are the thalamic nuclei with electrodes inserted there, and then they have these 5 different groups, one without treatment. So they didn't give treatment. They use apomorphine to control to see clinical response. So no treatment, no effect on changes in neural activity measured by the electrodes. 1 day of conditioning with apomorphine, then you see a little bit of activity. 2 days of apomorphine, placebo activity. 3 days of apomorphine, placebo, more activity. 4 days of apomorphine, preconditioning with apomorphine. Then the day that you give the placebo, the subthalamic nuclei is firing just as in the way that they were receiving the drug. So the title of this article was Teaching Neurons to Respond to Placebo. Although they did not do that directly, they used the conditioning, but consciously you can actually teach the neurons, especially if you have electrodes inserted on your head, to respond in a form of feedback, or what we call brain-computer interface, or the marketing level of neurofeedback. Since you have already electrodes inside your head, and they respond to a conditioning stimuli, then you can use behavioral techniques to promote those neurons to fire. It has been done, and it has been demonstrated in animal models. So since they already put the electrodes and the patient was in the hospital, you can move one step beyond and actually try to use behavioral techniques with biofeedback, neurofeedback, in combination with the drug or without it, because apomorphine has some of the very bad side effects, in order to see those neurons to discharge and to have responses in the clinical measurements. There is an association between placebo-activated neural system and antidepressant response. Here in this group, they took a group of major depression disorder patients, non-medicated, which is a little bit odd. And then they were told you will receive a fast active form of antidepressant or a normal active form of antidepressant. You will receive this for a period of time. And everything was just a placebo, but there were some of them, they received the real medication. And there were clear signaling that patients responding to placebo, they have activity in the nucleus accumbens, in the amygdala, in the medial thalamus, all circuitry involved in emotions, but also for the fMRI, in the scanner, they say, you know what? We have the fast active neurodepressant, antidepressant here, which was just a saline solution and then injected, and they show immediate activity in the same centers. Moreover, they show that this correlation between patients that responded to the placebo in the long run, they were able to predict up to 43% of the variability on those responding to the medication. So in this case, placebo responders, they tend to be better responders to the medication. For opioid and dopaminergic activity, so again, these crossroads of different neurotransmitters. I'm a neurophysiologist. I like electroencephalography. There are very few studies with electroencephalography. I like the electroencephalography because it's something that we can do in different environments. And here they use quantitative EEG to see the effects of placebo, again, in depression. And they divided in 4 groups after a lead-in of people responding to the antidepressant. Those who responded to antidepressant were removed of the trial. They just kept the ones who did not respond. And then they give the placebo and the medication. There was a big difference between those not responding either to medication or placebo and those who responded. But more important, there was a clear difference between placebo responders and medication responders. There is an increase of cordance, a form of a quantitative measurement of blood flow and power spectral analysis in the frontal lobes, and the opposite with those who responded to placebo. This effect has been described in patients responding to drugs. And also evoked potentials with lasers. And here was more about conditioning is really necessary. They see a difference in the amplitude of the evoked potential by pain, by decreasing the amplitude of the response in the vertex, which is a very interesting area. You expect to see activity in the sensory motor area. It was mostly on the vertex, where is a point where you can see the effect of the thalamocortical circuitry measured by EEG. And here they saw that either conditioning and non-conditioning, it didn't really matter. It decreased the amplitude of the evoked potential, the painful evoked potential, but also there was a decrease in the amplitude and in the clinical experience. Just because a matter of time, I'm going to start moving a little bit faster. So there are different substances, different neurotransmitters, conditions, and pathways that can be influenced by the way that we manipulate expectations or present the placebo. We are moving a little bit beyond that. Our group, Catherine Hall, Joseph Lascalzo, and Ted Ketchup, they are looking now to describe the placebo. This is extremely important because if you find a marker, then you can start designing some clinical trials with better way to differentiate who will respond and who not. But then later, we were involved in collaboration with a group in Brazil. This is about more than 300 subjects, 350 subjects. And we tested at that time the application of lidocaine injection, spinal lidocaine injection in low back pain. And you see, lidocaine had it was superior than sham and standard. But I was very surprised by this. The sham injection, which was just poking the needle on the spine, it was way superior than the standard form of treatment, that in this case was analgesics and physical therapy. Dinamara Rizzo Batistella is the health minister in the city of Sao Paulo. They really were considering to use this research because it's a social system to think about the use of standard treatment and start moving more into the more invasive treatment. But I said, well, that's interesting because it's just the effect of the expectation. And all of these trials, there were hidden placebos, which ethically represents a problem. So now we are thinking about this. It really happened if we actually mention to the subject that they will be exposed to the placebo. And in a very discussed trial here in Boston with Ted Ketchup and in irritable bowel syndrome, they show that open placebo has an effect. And then Ted, in collaboration with a group in Portugal, they showed these amazing results in patients exposed to open placebo. They told them, you will get a placebo, and it's not only the pain improvement, but also in disability scores. They were able to function better. So the video is not working here, so I'm going to show you this.
What was the placebo, Leon?
A shampoo.
Eu pensei assim, vamos deixar ver o que é que acontece. Não estava à espera que resultasse tão bem, e a verdade é que resultou.
Em pleno. Então esta semana foi fantástico. Eu voltei ao desporto, que era uma coisa que eu já há anos que não fazia.
Tive dores nenhumas, fui às compras, tive horas nas compras, não me deu nada, levei o computador para a escola, que era um fator limitante para mim e que não tive dores nenhumas.
So it was amazing. Eric, again, our medical anthropologist, is very conscious about the response of the subjects. They say you need to ask them what is going on. You need to understand what they experienced during the trial. So this is why, and now we're recording more their experiences. But so what's going on there? So you tell them you are going to receive nothing, and yet they respond. So it's amazing. It's just imagination. It's just the effect of the manipulation of what you are telling, or is all of this? Is the neurobiology behind that? And more important, can we start using that clinically? We are in the middle of a big problem in this country. So there are obviously many factors involved here, and something that I really want to start exploring more is the model, what we call the Bayesian brain model, which is basically in computational neuroscience, the way that you predict the probabilities of the brain to respond to something. So it's a little bit more complicated, but we are moving into that. And just yesterday, we submitted to the IRB our conditioning open label placebo for opioid reduction in inpatient with spinal cord injury at Spaulding. Following the same principle of Pavlovian pharmacology, we are hoping to reduce the dose of opioids by 10-day period by telling them you will receive a placebo. We will pair that also with other stimuli. We will put this with pine, or we're still not sure which kind of odor we will use, because the olfactory pathways are very good in conditioning subjects. So we have also all of our outcomes, but it's this point that we are really moving ahead from imagination and just the natural history of the disease to the concept of the inner substance, to now to understand that it has really a powerful effect. And we can, or we might start using it in the clinical practice. So to conclude, placebos are intrinsic component in the practice of medicine, like it or not. So it is there. The neurobiology of placebo is rooted in a complex system. We are now thinking from genes to neural networks, neurotransmission, obviously clinical responses. Expectations and conditioning are a fundamental aspect of this. To conclude with this, which I really believe is the case of why we want to use placebos now in combination with treatments, and to accept those placebos as something that is there, right? Not neglect them. There is many people involved here, the people from the placebo group, faculty, and my fellows in the Integrative Medicine Fellowship, the people at Spaulding Rehab Hospital, which I'm impressed about the response, because this trial is going to be in inpatients in the hospital, and all the practitioners, they need to be involved. The people from the Integrative Task Force, Judith is here. So they actually believe that the protocol that we are proposing, it will have an important effect in these patients, that they are obviously exposed to the addiction effects of the opioids, and everything that you know now is becoming a big problem. Thank you.
Well, that was fantastic. Thank you. We have plenty of time for questions. So you ready for some questions?
Yeah, of course.
Yeah.
Is there any evidence that the responder population for closed-label placebos are identical to those in open label?
Not at this point that I know.
Can you stay near the mic?
Oh.
Just so we can record it. And also, if you're going to ask a question, you were quite loud. You can use the mic and we'll have it.
Not at this point that we know. This is why I mentioned about the beauty of EEGs. Now the EEGs equipments are quite portable, and the analysis methods that we have are very easy to apply. One of the main comments that Lana Bass mentioned in her talk when she came from Denmark to talk about why they are not seeing this strong effect in the nocebo as compared with the placebo is that everything is in a controlled environment. As we know, clinical trials are rigid, structured environments. So we need to start moving more into the real world clinical field, like go to the hospital, go to talk with the practitioners. At this point, we are not sure if there is some difference. I expect the difference will be, for example, in polymorphisms in the pathways that promote the learning and plasticity. So, for example, in non-invasive brain stimulation, we know that people with BDNF polymorphisms, they do not respond well to the stimulation and neither to physical therapy. So it seems they cannot learn the techniques that they are being exposed, or the modulation is not having an effect because of the polymorphism. But we're still not very sure about that.
Fantastic presentation. I'm curious as to the story of what happened with your interaction with that company from Vermont that was selling the pills. Did that just sort of stop, or are you proposing a study where you have red color versus blue color?
No, it's more about Epic and pharmacies because it was a problem more about because we will use in a compound pharmacy to create the placebos. So the people at Spalding Pharmacy didn't feel comfortable with something that is in the market that they were saying, well, it's a supplement. So it was mostly an administrative issue. I know Ted is talking with the company to use placebos in other areas or in other centers that they are less rigid about that. But we really try. We actually put them together, the guys from the SIBO company with the pharmacy. At the end, the pharmacy said, we don't feel comfortable with this. So.
And comfortable, just to understand from the standpoint that they didn't, it was not...
Following their administrative processes, because the compound pharmacy will create the placebo, and it's an authorized pharmacy here in Massachusetts. Also, to use placebos here, you need to use pharmacies from the state. So they create the placebo, they send it to the Spalding Pharmacy, and the pharmacy will pack everything together with the oxycodone. So that was basically the main problem. It is cheaper. It was cheaper for us to get a bunch of SIBOs than to send...
But if you consider it as a supplement, then they still wouldn't allow it?
Yeah, that was basically the main problem.
I just wanted to respond to the question of responders. Can we predict them? And I think that's been one of the holy grails. Can we triage people? Can we identify who is going to be a responder and who not? And in which setting they may be more or less responsive. And I think one of the challenges is that even in the really well-designed clinical studies are really small samples, a couple hundred people. But what's happening now, and I think your response in terms of genomics was a good one, Catherine Hall and others doing these placebo studies are now like reanalyzing the women's health study where they have close to 40,000 people in full genomics, and they know who got real aspirin and who got sham aspirin, and they're starting to have big numbers so they can start to figure out in different contexts or in different settings who might be responsive. But it still doesn't have the clinical component in it, to answer your question. But I think the move towards the placebo allows us a little bit more granularity in responsiveness in different settings, which I think is really exciting.
Thank you for your very interesting talk. One of the things that I think a lot about for understanding the placebo effect is separating it away from some of these other things like regression to the mean and natural variability of disease. When you plan these studies and you're trying to figure out who is a responder and who is not, how do you separate out those components that have nothing to do or seemingly nothing to do with the psychological aspects that you've devoted your talk to?
So, well, first of all, if there is a natural course of the disease, you select. Like, for example, epilepsy is one of the best models to see this. We see the patients, they spike and then they control better. Again, going back to, do we have a questionnaire? Some of the questions are coming more, let's look into some personality profiles markers to see if somebody, like, kind of to hypnotize somebody. There is a questionnaire, if they is more prone to or not to respond to the technique. I think a well-designed trial is going to start basing more into or understanding better the whole concept of the ritual, the environment. So this is why when we move from the control lab environment like that we have in the neuromodulation center and transition that to the real hospital with the beds in the patient, the nurses, the interaction with the nurses. I was very impressed that most of the nurses, they were telling us, oh yes, we know the placebo effect very well, and we know that these guys, they will respond. Why? Because the immune receptors are quite easy to condition. So it's still a complicated factor. Again, as Peter mentioned, we are in the looking for the holy grail to look for the responders. But if there is a way, I think it's going to be more into to understand the personality of the subjects and to allow some flexibility into our clinical interventions, either for research or therapeutics.
What's the duration of the placebo effect? You showed those Benedetti's experiment giving different daily doses or different days, increasing days, and producing an effect. And does it tell us anything about whether there are changes in the actual structure of the neuropill or the underlying this?
We know, at least with drug conditioning, during the acquisition phase, the more days that you get the acquisition, so 2 will be better than 1, 5 will be better than 2, 10 days will be the ideal. You show that at least the effect will be ahead for another 5 to 6 days. If that correlates with neural activity, in the case of the Parkinson's study, will be difficult because in some point you need to take out the electrode and activate the stimulator. But now we understand the cure for the conditioning. So you introduce a reinforcer. So in the case of the opioid study, after 10 days, we can add a reinforcer of placebo, drug, placebo, 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 drug, just to try to expand the effect. Consolidation of learning is going to be based more about the whole phenomena moving around. We know that strong experience, they tend to be learned better than just superficial experiences. So in order to consolidate the learning, or in other words, to consolidate the strength of the synapses, in order to be there functional and firing during a period of time, it needs to be combined with behavioral techniques, plus obviously the pharmacological agent. We know that the length of the conditioning is kind of proportional with the length of the post-conditioning effect. And then there is a period of extinction. Then you start seeing that the effect is disappearing. So it's when you go in with a reinforcer.
When you talk about the behavioral effects in some of these ways of enhancing the placebo response, makes me wonder whether there are any data about the role of stress and cortisol in mediating some of these effects and increasing the stress response, the placebo response.
I think there is some research. I guess maybe Michelle, you might be more aware because the role of the enrichment of the experience, the practitioner being more communicative, spending more time with the subject, it might decrease levels of anxiety. So if you decrease levels of anxiety, maybe cortisol, you can measure cortisol going down. I would suspect that. I don't know in the work of enriched treatments, but it would be interesting to see if there are some markers that you, in some biofeedback studies, they show decrease on cortisol after deep breath techniques, muscle relaxation. So, and basically you're controlling anxiety response, the stress response. So yes, maybe by talking more with the patient, to be more attentive with the patient, you decrease anxiety, and I'm sure these markers, they will go down.
I was wondering, I was particularly interested in the sort of open label experiment with you're going to get a placebo. And it just prompted me to wonder if in this kind of investigation of what constitutes responders' psychology, in a sense, whether anyone has combined some of the older scales for measuring suggestibility, for example, like there's a Harvard index of hypnotizability that's been around for, I think, 20 years, and it's, you know, it just seems like it would be interesting to see if the responders also score high on a organized or a, you know, well-established scale of suggestibility.
Yeah, thank you for the question. That was a big point of discussion when we were designing this. This is a feasibility trial. We just want to show that it can be done in the hospital environment. The measurements are the assessments are straightforward, total equivalent dose of morphine, base scale, the quality of life scale. And it's basically to gather information for a bigger trial. For the bigger trial, we definitely are going to look for this kind of scales. We really believe it has an impact, and we need to look for. And also to train the health professional, to train the nurses to see, look, this guy has a specific profile. He will respond very well if you talk with him in a different way, if you take a little bit of more time with him, for example. But yeah.
I just realized that the other thing was when you said the nurses were able to kind of pick out or predict.
Yeah, absolutely.
We have time for one more question, but in response to that, Randy, a lot of people have looked for these predictors from hypnotizability to astrological signs or who knows what. And it's amazing how resistant it is to find one thing that predicts a placebo responder across a bunch of different environments. I mean, people have looked quite a bit. There's one question up here.
Thank you, and I
am
mindful of the time. I wonder if you could speak a little bit to these behavioral techniques that you use in a sense for the follow-up among patients.
Oh, well, I mean, there are different techniques. We do a lot of operant conditioning with neurobiofeedback, but you can also start moving to other integrative medicine techniques like meditation. If we know that meditation itself has an effect, that share common pathways with the placebo response, because the problem is that it's not only affecting the pain network, right? The pain matrix. It's moving beyond that. It's actually taking highly cognitive centers, which are basically the same centers that you see activity on meditation. So try to move away that. Obviously now in this time that we need to control the opioid addiction thing, well, let's get another alternative. I think that's the way to go.
One more quick question.
Just want to follow up on that question about separating placebo effects from like regression to the mean, which is really more like a purely statistical phenomenon. Mm-hmm. But that early slide that you showed, I thought was fascinating, where you're talking about the natural history. You had that curve, and then the placebo effect was actually able to influence that. Part of, if you think about healing, right, is regression to the mean, right? If something starts abnormal, it has a tendency over time to become more normal. But healing is really intertwined with that.
Yeah.
So how do you think about that, separating that from an experimental point of view?
That's a 6 million question, right? I mean, I moving away from the researcher into the practitioner, I know that it's not just the effect of the treatment, it's everything about I'm actually saying, presenting, and spending time with the patient. So, yeah, I know there is we see a lot of epileptic patients, so we know that there is this regression to the mean for them. But when you really start talking about why it's important for them to sleep well, to not be exposed to X or Y, then that difference effect, looking to that curve, it seems to start moving a little bit away. Or when we apply non-invasive brain stimulation, we know the effect. We have actually the EEG recordings with everything going on, and it's clear that at the moment of the stimulation, everything shifts to one point. Now, as a clinician, the healing component can push that a little bit more, can have a deeper effect. I don't know the answer yet. We are looking for it. But thank you.